Hey guys, all right, so we're going to do part 2 of the cardiac rhythm interpretation course, atrial rhythms. All right, so let's just jump right into it. Our first one we're going to talk about, normal sinus rhythm. So the natural pacemaker of the heart is the sinoatrial node, that SA node we talked about in that first lecture. This is found in the right atrium where the electrical impulse begins and then travels down to the ventricles. This rhythm indicates that the electrical conduction system is operating in an orderly fashion. And what you're going to notice on the rest of these lectures for all of the rhythms, there's going to be an example of the rhythm here, but then the boxes underneath are going to tell you what's considered normal for that rhythm. So in normal sinus rhythm, we can see that it's regular. Our rate's about 60 to 100. We have upright and present P waves. We have PR intervals of anywhere from 0.12 to 0.2 seconds, so 3 to 5 small boxes. And we have a QRS complex measurement of less than 0.12, so less than 3 small boxes. But if it falls into all of those categories, it's considered normal. All right, so what are the causes of normal sinus rhythm? Life in general, right? Like this is what we want. This is considered totally normal. Patient presentation, they're going to be normal, healthy, well-perfusing patient. Electrical conduction system is working normally. There's really no nursing considerations for this, and there's no intervention for this. All right, sinus bradycardia. So that occurs when the sinoatrial node fires at a rate of less than 60 beats per minute. But we know that the origin is still the SA node, even though it's less than 60, because of the normal P wave and the normal PR interval. You can see here our rhythm is regular, our rate will be less than 60, our P waves are still present and upright, PR interval is anywhere from 0.12 to 0.2 seconds, and our QRS complex is less than 0.1. So what are some causes of sinus bradycardia? Hypothyroidism, vagal stimulation, NMI, medications like beta blockers or calcium channel blockers, hypoxia, especially with kids. If you have a bradycardic kid, almost all of the time it's due to a hypoxic reason. And well-conditioned athletes. So this can actually be a normal response. This can be a normal thing for some people. What do our patients look like? Well, some patients might experience fatigue, dizziness, diaphoresis, pallor. Anybody that's hemodynamically compromised can experience syncope, and in extreme cases, even cardiac arrest. But again, we can have patients that are healthy and have a low resting heart rate of less than 60. We want to look at our patients. So our nursing consideration here is to really look at our patient. If they're not symptomatic, then it's not something that needs to be treated. So some patients who are sleeping experience a heart rate below 60 and they have no adverse effects, right? They can be sitting up and talking with you or be kind of active and still have a heart rate in the 50s and have no side effects. So if they aren't symptomatic, then there's no need to treat. But a patient who becomes hemodynamically compromised does require immediate intervention. So what does that intervention look like? So we're going to monitor a patient for symptoms of bradycardia, including dizziness and fainting. We'd follow our ACLS algorithms, which could potentially include using atropine or epinephrine, or temporary transcutaneous pacing if the patient's symptomatic and hemodynamically unstable, to try to get that heart rate up. Sinus tachycardia. So sinus tachycardia occurs when the SA node fires rapidly at a rate of greater than 100, but less than 150. And we can see here on our screen, we've got a regular rhythm. Heart rate is between 100 and 150. P waves are present and upright. Maybe difficult to see as the rhythm gets faster. It can get buried, so it can be really a little bit difficult, but they should be present and upright. PR interval is 0.12 to 0.2 seconds, and a QRS complex is less than 0.12 seconds. Causes of tachycardia include exercise, pain, dehydration, alcohol abuse, respiratory problems, fever, anxiety, hypoxia, hypotension, stimulants such as caffeine, a hyperthyroid activity like a thyroid storm. Patients may experience dizziness, shortness of breath, rapid heart rate, palpitations, chest pain, or fatigue. Nursing considerations, we just want to monitor closely, especially in patients with underlying cardiac disease. And our interventions. So really what we want to do is identify the underlying cause and treat it. If they're dehydrated, give fluids. They're having pain, give pain meds. Rarely do you need to escalate in a sinus tachycardia. We usually can just treat the cause. If you're working with them in rehab, let them rest and look at them. Are they pale, diaphoretic, nauseous? If they are symptomatic, then we can follow ACLS algorithms. We can try slowing the heart rate down with medications like beta blockers or calcium channel blockers and see if we can improve it that way if we weren't able to fix whatever the symptom was. So sinus arrhythmia originates from the SA node. So there's a normal P wave, but there is a cyclic change in the heart rate. It can occur with inspiration and expiration, and it typically occurs in young, healthy individuals and is a normal physiologic occurrence. So we can see in this one, the only thing that's abnormal out of these 5 phases is that the rhythm is irregular. Everything else looks the same as sinus rhythm. Rate tends to be about 60 to 100, P wave present and upright, PR interval is normal, QRS complex measurement is normal. What are some causes of sinus arrhythmia? Well, breathing in and out can be a factor. This rhythm is fairly normal and typically occurs in young, healthy adults. Due to the vagal tone that occurs with inspiration, the heart rate will vary. Again, patient presentation-wise, this is a normal physiologic occurrence, so you're probably not going to see anything abnormal on your patient presentation. Sinus arrhythmias occur in healthy individuals, commonly in children, so there's not any significant nursing considerations for us to worry about here. And we don't have any interventions unless the patient becomes symptomatic, and if they're symptomatic, there's probably more going on. So could they have a sinus bradyarrhythmia, where they have an arrhythmia like this, but it's too slow, or a sinus tachyarrhythmia, where they have an arrhythmia that's too fast. So there's probably something else that's going on, but just a standard sinus arrhythmia with a normal rate between 60 and 100, typically not going to see any symptoms, and there's not going to be any intervention. Okay, premature atrial contractions. So a PAC represents a contraction that originates in the atria, but not necessarily from the HSA node. When you look at the morphology of the P wave, you can see that it looks a little different from the P waves that are originating from the SA node. So our rhythm is a little irregular because we have irregular beats. Our rate, we're going to defer to the underlying rhythm. So we can count through. Typically, it still falls within the 60 to 100 category, but you can have it still be fast or slow, whatever your underlying rhythm is. The thing with premature atrial contractions is it's really just talking about that one isolated premature beat. It's not talking about the whole rhythm strip. So when we look at this, we wouldn't say this rhythm strip is a PAC. We would say that we have sinus rhythm with PACs, because those are the additional premature beats. P waves may be present, like you can see here, or hidden in another wave. So if that PAC happened too closely to the previous beat, it could be buried, so you couldn't see it. PR interval and QRS complex, all of that is still considered normal. The cause of this is usually unknown, although factors such as heart disease can be a contributor. Patients might complain of palpitations or feel their heart skipping a beat. Some patients aren't even aware that it's happening. The majority of PACs are benign and don't require treatment, so you can monitor them but not be alarmed, and there's no intervention unless there's something else that's potentially going on, but PACs alone are not going to require an intervention. Atrial fibrillation. So AFib results when there are rapid and disorganized electrical signals in the heart's atria, causing the atria to fibrillate. These disorganized rapid signals can cause the ventricles to respond and beat very rapidly. We can have AFib with RVR, that's rapid ventricular response. Now, AFib with RVR typically occurs when the ventricular rate is anywhere from 100 to 175 beats per minute, and this causes reduced cardiac output due to inadequate filling time. Patients can also have a controlled AFib, which means the ventricular response is within the normal limits, about 60 to 100. And they can also have AFib with SVR, so that's AFib with a slow ventricular response. It would be a ventricular rate of less than 60. Now you can see here, as we move through our rhythm, these are classic signs. Rhythm is irregular. We can't calculate any type of atrial beat because all we see are these fibrillatory waves. But we do see that the ventricular rate can vary, again, depending on if it's controlled AFib, AFib with RVR, or AFib with SVR. We don't have P waves, we have these fibrillatory waves. So we can't have a PR interval if we don't have a P wave. And our QRS complex is still nice and narrow. So some causes: heart disease, alcohol abuse, obesity, hypertension, family history of AFib. Most of the symptoms of AFib are related to the rapid ventricular response. Patients can experience shortness of breath, palpitations, weakness, chest pain, dizziness, fatigue, fainting, confusion. The fibrillations that occur in the atria prevent normal atrial contraction, which causes poor emptying of the atria, which increases the risk of thrombus formation. So if you think about it, the atria normally contract like this really nicely to force blood down to the ventricles, but now they're just doing this quivering motion. And so when that happens, blood can actually pool and not move nicely and be forcefully pushed down to the bottom of the heart and just kind of pool there, and that's where clots can form. The atria is also responsible for about 20 to 30% of cardiac output, So it limits your person's cardiac output. And what we say is that their atrial kick. So every time that it squeezes and it squeezes all that blood down into the ventricles, that is about 20 to 30% that it's giving that extra squeeze. And so when you lose that to just quivering, that can be pretty significant for some of our patients, especially some of our patients with heart failure. So it does limit their overall cardiac output. So what are some interventions if you encounter a patient with AFib? Well, we would want to follow our ACLS algorithms, right? So most of the time we don't see AFib with the slow ventricular response. We're seeing people that are having problems with AFib with the rapid ventricular response. So if that's what's happening and that's why your patient's symptomatic, then we want to slow that down. We can use diltiazem as a great medication that can be successful in slowing the rate and then controlling it with an infusion. Metoprolol can sometimes be utilized as well. And if the medications don't work, we could consider electrical cardioversion using our defibrillator or chemical cardioversion using a medication such as amiodarone. Anticoagulant therapy might be considered as well due to the risk of the thrombus, but this isn't that is not an immediate intervention, but it is something that should be considered, especially if you're going to do an electrical cardioversion and you're going to convert them back into a normal rhythm. Because if you think about it, if they've been quivering like this for a while and say they have a big old blood clot that does form, and suddenly you chemically or mechanically convert them, and now they're doing these good beats again, what's going to happen to that blood clot? It's not going to sit there anymore now that it's beating. It's going to shoot off and it's going to go through the system and end up in the lungs or further down in the heart or into the brain. And so we want to avoid those by considering anticoagulation therapy in our high-risk patients. So a flutter can be easily recognized by that sawtooth P wave pattern. It actually looks like a sawtooth. In this rhythm, the atria is beating faster than the ventricles can respond. The atrial rate exceeds typically about 200 beats per minute. As the flutter waves arrive at the AV node blocks some of those impulses. So a flutter can be challenging to diagnose if the ventricular rate is fast because those classic sawtooth P waves start to disappear. If we look at our bottom piece here, we can see the rhythm can be regular or irregular. The rate, ventricular rate is going to vary. We see flutter sawtooth P waves and not regular P waves. So because we don't have a normal P wave to be able to measure, we can't do a PR interval, but our QRS complex is still nice and narrow. There's a few different causes of a flutter: underlying cardiac disease, hypertension, hyperthyroidism, COPD, history of cardiac surgery causing scarring, history of atrial fibrillation. Now, patients can experience palpitations, increased heart rate, dizziness, hypotension, difficulty breathing, chest pain. A heart rate that is too slow or too fast can impact cardiac output, so it's important to monitor the patient's ongoing response to rhythm and therapies. There is an increased risk of thrombus in patients who have been in a flutter for a prolonged period of time, similar to AFib. Think about it, we're doing flutter waves instead of, we're not fibrillatory, but we're not doing the really nice squeezed P waves, kind of more of this flutter pattern. And typically you do have a conduction pattern. So like in this strip, you can see it's a 3-to-1. So we've got 3 flutter waves to 1 QRS complex, 3 flutter waves to 1 QRS complex. The ventricular rate tends to be within normal limits, but if it does increase, it can be hard to differentiate between AFib, A-flutter, and SVT, which we'll talk about in our next slide. So what kind of interventions do we do if we have a patient with A-flutter? Follow ACLS. Address that underlying cause, right? If there's not anything that we can change, then maybe we consider something like cardizem to try to slow the ventricular rate if it's too rapid, or we could consider synchronized cardioversion if the patient is unstable and we feel that they can't wait. So very similar treatments to our AFib with RVR for our A-flutter. If they're not symptomatic, then it would be something that we would really want to follow up with cardiology. Supraventricular tachycardia. So SVT occurs when there are episodes of rapid firing of impulses originating in the atria. We can't identify the exact cause at this stage because the rate is so fast that we cannot properly assess our P waves or our PR intervals. So you can see here the rate tends to be regular. It can be irregular, but because it's so fast, it can be really hard to see that it's irregular, if that makes sense. Because when something happens so quickly, even if you were to slow it down and it was irregular, when you speed it up and you push it all close together, it can actually look regular. So it can be deceiving. The rate is above 150. We can't see typically a P wave because it's just so fast that it could be buried in the previous beat, or there could be no P wave. We can't assess PR interval because we can't see P waves. But our QRS complex is still nice and narrow, so we know it's stemming from the atria. And the thing with supraventricular tachycardia is it's really an umbrella term that's just saying this is too fast for us to tell where it's actually coming from, but we know it's coming from somewhere in the atria. So it's called supraventricular, above the ventricles, tachycardia. And then what happens is once we figure out what the cause is, we can actually work on trying to determine what the actual rhythm is. So some causes to SVT: pulmonary emboli, congenital or genetic predisposition, exercise, idiopathic. So sometimes there's no obvious reason or cause. Drug use like cocaine and methamphetamines, smoking, high caffeine use, alcohol use, heart failure. Patients tend to present pretty poorly. So cardiac output becomes compromised because of that rapid heart rate and can lead patients to become dizzy and lead to syncope. Symptoms can be brief or could last for several hours. They can start and stop suddenly. Patients might also experience chest tightness, palpitations, shortness of breath, and anxiety. This rhythm can occur intermittently or last for a prolonged period of time because it is a supraventricular tachycardia. Again, all that means is the impulses are coming from somewhere in the atria, but it could be AFib, could be a flutter, but you don't really know until you slow that rhythm down and be able to fully assess what the underlying rhythm is. So for minimally symptomatic patients, we can consider having them perform a Valsalva maneuver. So that would be like bearing down. You can also have them sit up with their upper body forward position and cough. I've had patients before where we take the plunger out of the syringe and have them blow really hard through the syringe. That would kind of elicit the same response. Anecdotally, I haven't seen this work very often. And a lot of times we would have to move to pharmacologic interventions a little bit faster. So adenosine is the most common medication for this rhythm. Consider it the control delete. So what it does is it kind of pauses the rhythm to try to allow the heart to resume normal electrical beats from the SA node. And this doesn't always work. Sometimes what it'll do is it'll slow the rate down enough for you to see the underlying rhythm. And other times it doesn't do anything and you need to do another escalating dose of adenosine. If the adenosine does not work, or if the patient becomes more unstable, so let's say they now are altered mental status, they become hypotensive, then we want to look towards doing a synchronized cardioversion. If this is something that is minimally successful as well, then we could potentially be looking at transferring the patient to a facility that has the ability to perform a cardiac ablation or some type of a surgical intervention to try to stop this pathway from occurring. But typically, if medications don't work, then mechanical synchronized cardioversion tends to be fairly successful in getting this to slow down. All right, so let's just do a couple of practical ones. So how about in this? If we use the 5 steps of rhythm interpretation, is this rhythm regular or irregular? And when I look at it, I see that it's irregular. I look at my R to R waveform, and I don't see any regularity between. So the distance here is different from the distance here, from the distance here. I'm using my mouse on the wrong screen. The distance from here to here is different from this one to this one, this one to this one, and then continue on. There's really no pattern to it. What's the rate? So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So about 100 beats per minute. Do we have a P wave before every QRS complex and a QRS complex after every P wave? No, what I see really are fibrillatory waves. What's our PR interval? Well, we can't assess a PR interval because we don't have a P wave. And what about our QRS complex? Well, it is nice and narrow, so it's less than 2 small boxes. So what do I have here? I've got AFib. I have that classic irregular fibrillatory waves in between. That's our AFib. How about this one? So if we do our 5 steps, is our rhythm regular, irregular? This appears to me to be regular. Our rate is about 40. So you got 40 QRS 40. You've got 4 QRS complexes in your 6-second script. So 4 times 10 is 40. We have a P wave before every QRS complex, a QRS complex after every P wave. Our PR interval is consistent at about 0.02 seconds. And our QRS complex is nice and narrow. So what do we have when we have a nice and narrow QRS complex, good PR intervals, P waves normal? We know that the SA node is what's driving this because we've got a nice normal P wave, but our rate is just a little lower than we would expect because normal intrinsic SA node rate is 60 to 100. So what do we have? We've got a sinus bradycardia. All right, let's do another one. Using the 5 steps of rhythm interpretation for this one, are we regular, irregular? Well, I'd say that when you look at some of them, it looks like fairly regular, right? You're like, okay, that looks good. But then this guy, you know, if I marched it out, it would be regular still, but he looks like he came too early. All right, so there's your first clue. What's our rate? About 80, it looks like. We've got 8 QRS complexes in our 6-second strip. We have a P wave before every QRS complex, and we have a QRS complex after every P wave. But hey, you know, these P waves look a little different from these P waves that are marching out on all of the others, right? So I'm going to keep my eye on that. PR interval is consistent throughout, so I'm happy to see that. But, you know, this one might be a little prolonged. I'm not really sure. It looks a little different. Our QRS complex, it's nice and narrow, so we know it's coming from the H band. So what do we have here? We have an underlying sinus rhythm because we see, okay, these guys march out really well, but then suddenly this premature beat gets in the way. So that's our premature atrial contraction. We've got a sinus rhythm with a premature atrial contraction. We actually have 2 PACs in this strip. We've got one here and we've got one here. All right, last one. Is this regular or irregular? Well, it looks pretty regular based off of the R to R interval, but again, it can be kind of hard to tell because it's really fast. Our rate is about 190. I'm not going to make you count that out, but it's about 19 QRS complexes in this strip. Is there a P wave before every QRS and a QRS every P? Well, it's really hard to tell because there could be something. You could argue maybe that's a little P wave. Maybe there's something in there. But it's really difficult to see because it's so fast that if there is something there, it's being buried in front of it. So we can't assess a PR interval, but our QRS complex is still nice and narrow. It's less than 2 small boxes. So what do we have when we have a really fast rhythm with a narrow QRS complex? We have SVT, supraventricular tachycardia. All right, guys, so that was all of our atrial rhythms. The next video is going to be about junctional rhythms.